We have another surgical giant, surgical hero, to be honored here. We're going to talk about Stanley J. Dudrick, a surgical hero. Dr. Pascal Fuchshuber is going to present the video.
First, I would like to thank the college and the Video-Based Education Committee, and in particular, Dr. Richards and Dr. Schweitzberg for having the idea and implementing and innovating the idea of having a historical session like this. It has been an immense privilege for me to be able to do this video with Dr. Dudrick. I think probably besides saving somebody's life by doing surgery, this is probably will be the biggest contribution to this profession that I will do in my entire life. There has been said that there are three major things that made surgery possible: asepsis, antibiosis, anesthesia. None of which are really surgical things, but without those we wouldn't be here. We wouldn't exist. The fourth thing that is the reason we're here and we can do what we do today is total parenteral nutrition. So we are very privileged today to have the man this video is going to talk about in the room today with his wife. And there's really nothing for me to say beyond this, because everything that you need to know about this man will be in the video. If we could please run this. Total parenteral nutrition has been recognized as one of the most important achievements in modern medicine. It has saved millions of human lives, and its impact on medical practice cannot be overestimated. Let me take you on a brief journey on the inception, development, and clinical application of TPN and the celebration of the man responsible for it, Dr. Stanley Dudrick. Stanley Dudrick was born in a small coal mining town in Pennsylvania, April 9, 1935. His parents were first-generation Americans who immigrated from Poland in the late 1800s. Both grandfathers were able to secure employment in a Pennsylvania coal mine under the condition that all their sons, including Stanley's father, had to work in the mines for free until age 21.
It was wonderful training and wonderful discipline, and they expected so much from me, but they also wanted to make sure that I never had to set foot in a mine in order to make a living, and that I was going to get the best education that the family could afford for me. And that's where I started.
The influence his father had on Stanley's character and work ethics set the foundation for his ability to overcome adversity and remain perseverant.
He was a taskmaster for which I'm very grateful, and I can't say enough good about him because he taught me so much that at the time I wasn't even sure I was learning or appreciating it.
Stanley Dudrick decided very early in life to become a physician, and it is befitting his character that this decision was made against the advice of others.
Nobody said, oh, you could do it if you really want to. They all kind of told me how improbable it would be that I'd make it. Of course, that was fantastic stimulus for me. And I was going to make it for no other reason to prove them wrong. And that's been part of my character ever since. The best 4 years of my life, barring none, were the 4 years I spent in Lancaster, Pennsylvania at Franklin and Marshall College. It transformed me from a bumpkin kid from the coal regions to a scholarly thinker. And I can remember growing tomato plants hydroponically and changing the different concentrations of magnesium and calcium and seeing what effect it had on the tomato plants. was something I'll never forget. In medical school, I spent most of my time learning how to be as good a physician and surgeon as I could possibly be, and I wanted to be the best. The drive then to be the best possible surgeon I could be drove me into the laboratory. The operation was often a success, but the patient either had complications or died. I remember talking to Dr. Rhodes about how frustrated I was, that I thought I was participating in excellent surgical procedures, and I thought they were about as good as you could do, from my vantage point, but yet the patients were declining and dying in a few days. And I told them that maybe I wasn't good enough to be a surgeon. And of course I blamed myself for my inadequacies, but the next morning Dr. Rhodes detected that, put his arm around me and said, "Come over here." And he said, the common denominator is they were all operated on the second or third time in a short period of time, and they all were malnourished. And he said, "I think if you feel that strongly about it, you should go in the laboratory and work on it instead of quitting." And that was the magic word, quit. I said, "Yes, sir, I want to go to the lab, see if I could do something to show that total parenteral nutrition was a feasible, safe, practical, effective thing to do." I came around at the right time in history to take advantage of the accumulated knowledge, and the technology was burgeoning in this country at that time, and I had the right mentor in the right institution in the right department. I didn't even realize when I got into it that that was one of Dr. Rhodes's pet projects. I was that naive, and he was quite eager to see me try to show that it could be a clinically effective technology. We first wanted to show that we could devise a technique for providing all the nutrients. In order to do that, we had to be isotonic or near isotonic, which limited how much food substrate we could give by vein. We knew that it was not going to be a practical way to carry it forth, and that we'd have to concentrate the nutrients and then figure out a better way to deliver them. The concept of total parenteral nutrition was thought to be impossible, and even if it were possible, it would be impractical, and even if it were made practical, it would be unaffordable. And people regarded attempts to create total parenteral nutrition technology as a pursuit of the Gordian knot. If it is impossible, I want to show myself that I couldn't do it. I had to figure out what was available. We couldn't give more concentrated solutions by peripheral vein. We didn't have proper catheters. We didn't have solutions available. I had to produce substrates that were not available commercially. And then I had to put them together in a solution that wouldn't precipitate, so that there were compatibilities. Then I had to show that I could sterilize them. Then I had to show that it had shelf life. In the meantime, I was trying to develop catheters and ways to administer the solution, and I knew I would have to go into a high-flow system like the subclavian vein or the superior vena cava. There was not a single intravenous pump being used in the United States for infusion of IV fluids at that time. And there weren't even complete vitamin mixtures. We had vitamin B and C, that was it. The thing we wanted to do was to develop an experiment that would prove to surgeons beyond a shadow of a doubt that it was worthy of their effort to feed people entirely by vein adequately. So we thought of a simple model. If we could support growth and development in a growing animal. Well, we first chose just 2 mongrel dogs. I went to the pound and got $2 puppies and put a catheter into the superior vena cava through the jugular vein. They grew for 24 days. The 24th day, we were having a meeting in the Harrison Department of Surgical Research. Dr. Rhodes came in, and then he asked me the killer question, "And which peripheral vein are you using to infuse, Stanley?" And I said, well, Dr. Rhodes, I'm using the external jugular vein. He said, yes, but where's the tip of the catheter? I said, well, you got me. It's in the superior vena cava. So he says, you're feeding them centrally, not peripherally. I said, yes, sir. And I thought I was going to get fired because he wanted us to be able to feed peripherally. He did not believe that American physicians and surgeons would accept central venous infusions. Smiled and said, well, you can't beat success. I need some money to buy some pedigreed beagle puppies because the Atomic Energy Commission has defined the nutrient requirements for beagles. Beagle mother usually stops feeding about 8 weeks. We fed them from 8 weeks to 12, picked one of each pair. After 4 weeks, put a catheter in one of them and fed that one entirely by vein afterward, while his litter mate was being fed the ideal oral diet. And much to my delight, the animals grew comparably and developed comparably. We showed for the first time in any animal species that you could feed entirely by vein for up to 257 days.
So you spent 257 days with the beagles?
I never left them for longer than 3 to 4 hours that whole time. We had to develop a swivel counterbalanced infusion apparatus that Harry Vars and I worked on and connected them then with a speedometer cable to protect the IV tubing that was inside from the swivel down to the back of the dog. Actually, a speedometer cable from Manimo and Jax, the Pep Boys. And matter of fact, when I was at the Pep Boys getting speedometer cable, I found some polyvinyl chloride tubing there, and it was autoclavable, and it did not cause inflammation either in the fat or in the vein. That ended up being the catheter that I used for about 5 or 6 years until the commercial people then began to manufacture medical grade catheters for us. An opportunity came up at Children's Hospital. Diller Groff, who was a pediatric surgical fellow with Dr. Koop, he called me up and said, Stan, rumor has it that you've been growing some puppies in the laboratory. And he said, we have a baby down here that's not going to live unless it gets parenteral nutrition. He said, could you come down and give us a talk at Children's? So the auditorium was packed. All talked about it, I guess, and then he called me the next day and said, Stan, we'd like to ask you, would you come to Children's and, this is a quote, play your puppy trick on this baby for us. Dr. Koop welcomed me there, and a giant of a man, as Dr. Rhodes was. He let me do what needed to be done for the baby, and I came down, put a catheter in the same way as the puppy, through the jugular, external jugular, threaded it down into the superior vena cava, then I threaded it subcutaneously from the neck behind the ear, and I brought it out up here. That allowed the baby the pinion easier without kinking, got it out of the kink of the neck, got it away from her secretions. She could barely reach it with her hands. So for a lot of reasons, but the main reason was to have a tract, because we had a tract from the skin site to the central vein in the animals, and we try to duplicate that in the baby to reduce infection. We fed her on the first run for 7 weeks, and she grew from 4 pounds to 6.5 pounds, increased in length about 5 or 6 centimeters. She clearly grew and developed normally and became active and animated, and at that time we changed the catheter, but then we eventually fed her for 22 months. We used 14 different catheters. Some of them were cut downs. Some of them were percutaneous. Later on, we even did a couple subclavian punctures on her. And so it was the first long-term total parenteral nutrition in a human infant. And we grew and developed her. And it was the longest term anybody had been on TPN for that time. And it really was almost, sent by God. Unfortunately, a decision was made by an anonymous committee that was assembled by the hospital to decide whether or not we were going to continue to feed her by vein, and the decision was that we should only feed her by standard of care. And so after 23 months of age, we just fed her 5% sugar, water, some amino acids, some vitamins, plus whatever she could eat. And a month later, she died of malnutrition. And I still think about that baby. I had some people say, you're going to kill more people with this technique than you're going to help. And they said that in public. But deep down, I knew that what we had done was truth. We were able to write a paper on, I think, 18 other similar catastrophic abdominal events on fellow SEALs and gastroschisis problems in children. And those had about an 80% mortality prior to TPN. And in the series we did, they all lived. And so we took an 80% mortality and converted it to 100% salvage. And if you apply the TPN concept and technology to the premature infants, the little babies that weigh 1 and 2 pounds, the very or extremely low birth weight infants, literally millions of those babies have survived since 1970 that would have died without the TPN as an adjunct. In the old days, they almost all died. And the looks, the eye contact that I had with the nurses and the mothers and fathers in that ward, I will never forget. It pierced to my very soul. And so you can't help but feeling that you did a little bit of good. And I'm very grateful to experience some of that.
Dr. Dudrick continues to be active in surgical education, research, and clinical medicine, supported by his wife, unlisted co-author, and collaborator of 6 decades, Terry, and his lovely family. Through his persistence in developing total parenteral nutrition, Dr. Dudrick has saved countless lives all over the world, trained and inspired a great many surgeons and scientists, and received a myriad of awards and honors during his long career, including the ACS Jacobson Innovation Award, the AMA Brookdale Award in Medicine, the American Surgical Association Medallion for Scientific Achievement to Surgery, the Ladd Medal of the American Academy of Pediatrics, the Goldsmith Award of the American College of Nutrition, and the Society of Surgical Oncology Distinguished Service Award. But nothing more pointedly expresses the magnitude of his accomplishment than the testimony of his patients and colleagues.
My name's Wyatt and I'm 11. My name's Anderson and I'm 13.
My name is Sean Tittle. I trained under Dr. Dudrick. My daughter Anderson was born 4 weeks early and was septic after birth. She was on TPN for a week, and she's going to start high school next year. My son had RSV when I was a chief resident, and he was in the intensive care unit, intubated for 16 days, and he was on TPN the whole time. And every day Dr. Dudrick would call me, and they're both pretty good math and science students, so I'm hopeful that they're going to be inspired by the person who saved their life.
Dr. Stanley Dudrick revolutionized the care of patients with the development of central venous line catheterization and utilization of total parenteral nutrition. Millions of lives the world over have been saved because of this development. I first met Dr. Dudrick in the summer of 1967. I was a college student. He took me under his wing. Later that summer, my father died, and he became like a surrogate father to me over the ensuing years. My entire career, in many ways, has been under his tutelage. He is truly a hero in medicine and surgery.
Can we have the lights? I would like Dr. Dudrick and Terry, if you both could please stand up and please. Dr. Dudrick, would you like to make some comments at this point, maybe?
As always, a small minority of people get the majority of credit for the majority of work done by the majority of their colleagues. And I'm really grateful to Bill, to Steve, to Pascal, and the other members of the committee of the American College of Surgeons and the college itself for the great honor to include me. In this list. I still feel like I'm a bumpkin kid from the co-regents, even though I'm pushing 80. And to be together with giants like Dr. Bursey and Dr. Cooley and Dr. Olga, it's a humbling experience. And although it's called legacy, the legacy isn't the four of us. The legacy are the people, like the Reardons and the Palestis and the Tittles and the others that have supported us and shared with us the wonderful creativity, discovery, the joys of success and the failures, and provided us with the happiness and satisfaction of having the feeling that we've left the world a little bit better than we inherited it, and knowing that we're leaving it in marvelous hands, and that the future, despite all of the turmoil around us, still looks bright as long as we have young, talented, energetic, motivated, conscientious, idealistic people who live the values that their parents and colleagues instilled in them. Thank you so much for letting me be part of this.
I asked Dr. Dudrick if he would be willing to take a few questions. I have my own testimony that as a young surgical resident at the University of Maryland, Dr. Dudrick came and gave a lecture, a very inspiring lecture, that inspired me personally to go into surgical research and to go into surgery. It was a very inspiring lecture about the development of TPN. So I can say that you've inspired hundreds, if not thousands, of young people in your life. My question to you is, what was the low point in your development of TPN?
I guess the low point was we were in an auditorium at the University of Pennsylvania like this, and a giant of American medicine, Arnold Relman, the chairman of medicine at Penn at that time, who ultimately became the editor of the New England Journal and other wonderful things, asked me to give a talk at the Grand Rounds in medicine. And it was jam-packed. I never saw any more people in there. I'm sure the oxygen content was marginal in that room. And I gave my piece about what we were doing with the animals and what I thought might happen in the future. And it was he who then got up to the podium, and I was a fourth-year resident. and trying my best, probably exhausted and smelling like a dog and an unshaven, sweaty guy. And it was he who said that he predicted that although these results were impressive, that I would kill more people by trying to propagate that technique than I would ever help. And to kind of be dashed down to the ground by such a giant was my low point. I actually was had a reactive depression almost for a couple of years because I felt so bad. I knew what I was doing was right and appropriate and had to be done, and yet I always had that little fear of failure in my back that he instilled in me. But it was an invaluable lesson, because never again would I ever in my career do that to a young person. And part of my mantra is that I'm a service organization. I serve my patients, and I serve my colleagues and my societies. And my goal is to help every young person who chooses to seek my counsel or advice, to provide to them within the resources available to me whatever I can possibly provide them so that they can achieve their God-given potential. And if I've done that for them, that's all they can ask of me. And after that, it's up to them. And so you have to take the potholes and the failures and the low points and to turn them around into success by hard work, perseverance, conscientiousness, resilience, and resourcefulness. So I've over-answered the question, I'm sure, but I think that's our legacy. And as long as we keep trying to do that to our young people and not expecting anything from them except their very best, this world will have a future.
Stan, Steve Schweisberg, training in Houston, I had the privilege of scrubbing with Dr. DeBakey and Dr. Cooley. But one of my most memorable operations was you had just come over from the University of Texas to St. Luke's Hospital, which I'm sure was not a high point that week. And all of a sudden, we saw this magical name on the board, Stanley J. Dudrick, on the board, and we all looked at each other going, are we supposed to scrub in to this case? So the chief resident said, I don't know, why don't you go find out? And I walked into the room and I said, well, Dr. Dudrick, I don't know if I'm supposed to be here. And he said, well, now that you're here, why don't you scrub in and see if you can learn something? And I just have never forgotten that I got to scrub. It was only a breast biopsy, but I got to scrub with Stan Dudrick, and I have told that to students. And if you fast forward, 30 years to when you were at St. Mary's, the thing that amazed me the most is your students and trainees and residents love you, and that you have put in just so much of your heart and soul to their education. It was no surprise to me because, I was at Baylor, you took a Baylor surgery resident and you didn't miss the opportunity to teach something at every moment. And you're a role model for all of us who would ever choose to find a hero to emulate. So I thank you for 1982 and every day since.
Thank you so much, Steve. And I will tell you, I can remember that operation. It was a breast lumpectomy, and it was at 8:30 at night.
Yes.
Because that's when I got on the schedule. And the patient did fine, and I never forgot Steve for that. And I guess to follow up on that, my family says that I have three families. I have a laboratory family of animals and technicians and other people that help, and I have a clinical family of students and residents and patients and colleagues, and I have a biological family, my lovely wife Teresa, and who Pascal alluded to, and I thank him for that. And my family has no doubt that they're number three, and I treat everybody else as if they are my family, and it's a simple
simple formula, but I'm a simple guy, and I can't forget it if I make it that simple. Thank you again for the honor, Bill.
One last question. So this is Bill Richards again. Is there room for more surgical innovation?
Oh yeah, the world's incredible. It's like a burst of atomic energy. It just goes out infinitely, and what really bothers me every once in a while is people will come to me and say, well, there's really nothing more to do in nutrition or metabolism because you've done it all. We haven't even scratched the surface. And to get down to the cellular level, to the cell wall, to the mitochondria, subcellular, and to really understand, and now to apply the genome and the microbiome. When you think of multiplying all of that, it's just infinite. And I just envy the youth of today, the opportunities they're going to have to advance knowledge and provide technology that we can't even comprehend at this point in time, because the human mind is such a magnificent structure, just barely loafing, really. All of our minds have loafed, and yet we've accomplished. Wait till we get that thing in overdrive, and it's going to get there. And the world is going to be a magnificent place with the innovation, technology, and the ingenuity and energy of our legacy here at the American College of Surgeons.